to the embryo in the fetal period. This yellow color is going to remember you the foregut. The superior part is the foregut, midgut and hindgut. Look at to the foregut. About the foregut, please remember the fourth week. This fourth week in embryonic period is important about the respiratory system. Why it is important? Because a small diverticulum, a small bud is going to be appear at the ventral surface of the foregut. This yellow tube is going to remember you the foregut. The superior part we call foregut. The foregut in the ventral part in the fourth week, you are going to find in fourth week a small diverticulum, a very small bud that we can call respiratory bud or lined bud. So we can call lined bud or respiratory diverticulum. This blue color is going to remember you, this blue color is going to remember you, this blue color is going to remember you the respiratory diverticulum. It is going to be appear at the ventral surface of the foregut, and it is going to grow downward. So it is going to grow downward. When it is going to be appear in which week? Fourth week. Never forget. Fourth week is important for appearing of the respiratory diverticulum or lined bud. This diverticulum is going to appear in the foregut, and the foregut, the inner layer of the foregut is going to derive from the endoderm. Do you remember in embryology, endoderm, mesoderm, yes? Now the endoderm that belongs to the foregut, this yellow color is going to remember the foregut, and the endoderm here is going to make a location for appearance of this diverticular respiratory diverticulum. What happened? That this location, this blue color, this diverticulum is going to appear here. Something or interaction to each other. Something happened here. Means the retinoic acid. The retinoic acid is going to increase. The upregulation of the retinoic acid is going to appear here in the adjacent mesoderm. When the retinoic acid in adjacent mesoderm here is going to be increased, the upregulation of the retinoic acid is going to change something in the foregut, in the endoderm of the foregut. What happened in the foregut? In a spatial area of the foregut, something upregulate, something is going to appear. Here you have the upregulation of transcription of TBX4. Means TBX4 in the foregut, in the endoderm of foregut is going to appear. So the retinoic acid in the adjacent mesoderm upregulate and attach, stimulate the foregut in the spatial location. In this spatial location, what happened? One transcription factor is going to increase. What is this transcription factor? We call the TBX4. Only you know this is enough. You don't need to read in detail about all of this structure. So only you should know in the adjacent mesoderm, the retinoic acid increase. In the foregut, you can find that the transcription factor TBX4 increase, and it is going to show us that the location of appearance of the line bud is going to appear here. It is again another picture that it is going to remember you the position of the line bud or respiratory diverticulum, not in the dorsal surface, in the ventral surface. Okay, do you have any question here? No. Now, something happened something are going to drive from the endoderm, something are going to drive from the mesoderm. About the mesenchyme, the mesoderm along the respiratory system is going to prepare for us the cartilage, the connective tissue, the muscle. Okay? So about the lung bud or respiratory diverticulum, the lining of the respiratory diverticulum is going to arise from the endoderm of the foregut. What about the cartilage? What about the muscle? What about the connective tissue? They are going to arise from the mesenchyme, from the mesoderm. That's easy, yes?
Yes.
The muscle of the respiratory system arise from which layer?
Mesoderm.
The inner layer of the respiratory system arising from the endoderm. Now you know the expiratory system is going to form for you the larynx, trachea, and the bronchiole and the lungs. Okay? All of this structure, the inner layer arising from the endoderm, and the muscle, cartilage, and the surrounding connective tissue are coming from the mesoderm. Now, here, if you look at this picture, it is going to magnify the foregut to be able to show you how the respiratory diverticulum is going to appear and how it is going to develop caudally. At the first, you have a lung bud, a diverticulum, a small diverticulum. In development, it is developing inferiorly. It is developing inferiorly, caudally. When you are going to look at the lumen of the foregut, at the first, the lumen of the foregut is in connection with the lumen of this respiratory diverticulum. But very soon, two ridge, two septum are going to appear and go to the midline to attach to each other. Very soon, the anterior tubule we are going to call the trachea, and the posterior part we call the esophagus. So esophagus derived from foregut. Okay? The ventral part of the foregut get a bulge, get a bud. This bud get dilated, get longer, go caudally, and make the diverticulum of the respiratory system. With the time, with the development, two ridges in both sides, they are going to flow to each other to the midline. At the end, this is going to divide to two tubules. Anterior tubule we call trachea and posteriorly we call esophagus. It is easy. Now, you should know that during this development, it is possible some defect, some abnormality appear. Here you are going to look at some of the abnormality. It is possible the proximal part of the foregut end to a pouch, and inferior part of the foregut connect to the trachea. Here we can think about one kind of the abnormality. The inferior part of the trachea is going to connect to inferior part of the esophagus. It is possible two proximal and the distal end of the foregut, both of them make a blind pouch and never connect to each other, never connect to the trachea. This connection make a very narrow duct that we can call fistule. This fistule in our body are going to make problem for the patient. This fistule means you have a connection. Yes, this connection is very narrow, but you have a connection, for example, between the trachea and the esophagus. Sometimes the connection is such as this. It is such as the H word in English. It is such as the H form. it is possible the proximal part is going to connect to the trachea by a fistula, and the distal part make a blind pitch. So we have so many types of the atresia. We have so many types of the abnormality, defect. Here again, you are going to look at some type of the defect or abnormality that the esophagus is going to connect to the trachea with two fistulas, with one fistula, the proximal part, and to a blind pouch, and the inferior part also is a blind pouch. We have so many defects, and obviously, vectorial, you should remember vectorial is vectorial. This vectorial association is going to remember you that if in a baby you be able to find one defect, it is possible in this baby you find another defect too. Okay? Commonly, if one abnormality appears in one baby, it is possible another abnormality also will appear. So, with the tracheoesophageal fistula that I explained for you here, it is the tracheoesophageal fistula, okay? With the tracheoesophageal fistula, we are able to explain for you that some of the abnormalities are going to associate it, such as the cardiac defect, such as the anus atresia, such as the esophageal atresia, such as the renal abnormality, such as the defects in the limb. Okay? So when in one baby you find a defect or abnormality, it is possible in this baby you will be able to find another defect or abnormality. In this picture, I show by the vectorial association. We remember you the abnormality of the vertebra. This A, remember you the anus atresia. This C, remember you the cardiac defect. This TE, remember you the tracheoesophageal fistula. And this R is going to remember you renal abnormality. This L, remember you the defect in the limb.
We should remember all of this. This is an exam. We should remember it.
Vector in your book you find alignment about the respiratory. When you reach the respiratory system, in respiratory system, in the first page, they wrote for you the vector and explain for you. The V is going to remember you the vertebral abnormality. Okay, every of them are going to explain for you.
Doctor, how could that affect on that factors? For example, cardiac.
So look at me. At the first, the baby is a 1 cell, 2 cell, 4 cell, and with the time it is going to develop. Something happened. For example, I told you before that the embryonic period, the fetal period, is an important period in our body, in our life. If, for example, the mother become angry, if the mother use from the drug, okay, everything can be a factor that they are going to prevent the normal development. Because the heart is going to develop, the lung is going to develop, the brain is going to develop. Something happens in a small period, so some of the abnormalities are going to appear. Okay? All of them appear in fetal period. Now in this picture, if you look at this picture, here you are going to look at to carina trachea. Do you remember the carina trachea?
Yeah.
It is the last cartilage in the trachea. In the trachea, you have U4, C4 cartilage. The last cartilage in the trachea here make a common cartilage at the beginning of the main bronchus. This inside of the trachea, you are going to look at two lumen. Here, you are able to find a fistula, 3 lumen. Here, normally we have 2 lumen. When we go inside of the trachea, in fistula, it is possible you find 3 lumen. This 3 lumen is going to remember you that the fistula is going to happen here. In the embryology, later, you are going to read about the pharyngeal arch. Pharyngeal arch. Some of the pharyngeal arch are important. Some of the pharyngeal arch are important. For example, the 4th pharyngeal arch, the 6th pharyngeal arch are going to prepare for you the cartilage of the larynx. So the cartilage of the larynx derive from which pharyngeal arch? 4th and 6th pharyngeal arch. The 4th pharyngeal arch is going to innervate by the superior laryngeal nerve. The 6th pharyngeal arch is going to innervate by the recurrent laryngeal nerve. So you can find the larynx is going to be innervated by the 10th cranial nerve. Do you have any question here?
No.
Pharyngeal?
10th cranial nerve, what's in 10th cranial nerve?
What?
Vagus. Vagus is the 10th cranial nerve. It is going to supply the 4th and 5th and 6th pharyngeal pouch. So they are pharyngeal arch. So everything that arises from the 4th and the 6th pharyngeal arch are going to be innervated by the branches that belong to the vagus nerve. Do you have any question?
The 6th pharyngeal arch gives to what? What does it?
The recurrent laryngeal nerve is responsible to innervate.
No,
The
I mean.
4th and 6th pharyngeal arch are going to prepare for you the cartilage of the larynx. Okay? The larynx, some part of the larynx that derives from the 4th pharyngeal arch is going to innervate by the superior laryngeal nerve some structure that they are going to derive from the 6th pharyngeal arch. They are going to innervate by the recurrent laryngeal nerve. In this picture, again we are going to explain for you only when the septum between the trachea and esophageal that we call the tracheoesophageal septum is going to divide the esophagus from the trachea completely. Superiorly, both of them are going to connect to the pharynx by this foramen that we can call the laryngeal orifice. These two, yes, in developing are going to divide from each other, but superiorly, most of them are going to open in the pharynx. This is the opening of the laryngeal orifice. Do you have any question? No? Are you ready? I ask you some question? No. Do you want to get 20 from 20?
Yes.
No. Okay. Here is the development of the trachea and the lungs. What happened? At the first, the trachea is going to be formed. To get formed, it is going to develop inferiorly. In each side, make the lung buds. Each lung buds to the small subdivision. For the right lung, this lung bud is going to divide to 3 branches. And in the left lung, it is going to divide to 2 branches. Do you remember yesterday I told you that the left lung consists of 2 lobes and the right lung consists of 3 lobes? Here we are going to look at that. Here, there. What's the problem? So at the first you have the respiratory diverticulum. After that, you have the lung buds. After that, they are going to divide to make the main bronchus. Main bronchus are going to divide the secondary division. In the right side, 3 division. In the left side, 2 division. And they are going to enter and developing and complete the respiratory tree. In adult, normally this respiratory tree is complete. Now we have so many periods, so many phases. For example, one of them we call pseudoglandular phase or pseudoglandular period. This pseudoglandular phase is going to be happening during the 6th week. It is going to appear after the 6th week. Now here, now notice here, what happened here? All of these subdivision, all of this branching are going to be continue to have some subdivision. At the end, you are going to find the respiratory tree. If you notice, when this bronchus, when this respiratory bud, when this lung bud are going to grow, are going to divide, they are going to invaginate inside of the pleurer. This pleurer is going to arise from the mesoderm. The somatic mesoderm later is going to bring and prepare for you the parietal pleurer. And the mesoderm near the respiratory bud, the lung bud is going to prepare for you the visceral pleura. Between the visceral pleura and parietal pleura here, I am able to show you the pleural cavity. So the pleural cavity is between the visceral and parietal pleura. The parietal pleura is going to drive from the somatic mesoderm. And the mesoderm exactly near the lung bud is going to accompany this subdivision and make the visceral pleurer. Now here in your book again you find these subdivision. During this subdivision you are going to find some period, some phase. One of the phase we call embryology. One of the phase we call pseudoglandular. In pseudoglandular, look at the pseudoglandular phase. What happened here? This pseudoglandular is between the 6th week and the 16th week. What happened for the respiratory tree here? The terminal bronchioles are going to be developed. The terminal bronchioles are going to be developed. In the canalicular period or canalicular phase, it is going between the 16th to the 24th or 28th. This 16 to 28 phase that we call the canalicular, the terminal bronchiole are going to have some subdivision. They are going to form the respiratory. They are going to form the respiratory bronchiole. Which bronchioles appear in pseudoglandular? Terminal. Which bronchioles are going to be appear in the canalicular? Terminal. The terminal bronchioles are going to appear here. And after the canalicular, you have another period. This period is going to be continued to the birth. And this period we call the
Circular.
Circular. In the circular, you can find the alveolar guard and the primitive alveole. Here, I'm able to show you the primitive alveole, the respiratory sac, the primitive alveole. But they are primitive alveole, not mature alveole. You need the mature alveole to be able to breathe after the birth. During the last 2 months, something happened. Some of the primitive alveole are going to change to mature alveole. So the number of the mature alveole in the last 2 months is going to increase. And so if a baby is going to come out, births happen very soon, it is possible that the baby can be survived. But if the baby wanted to have the birth very early, because this respiratory tree is not going to be complete, normally it is going to get dry. Again, the line development is visible here. If you notice, you can find that at the first, you can find the bud of the line. This bud of the line are going to develop and have some subdivision. Before the birth, you have around 70 some subdivision. After the birth, you have 6 subdivision. After the birth, the subdivision is going to be continued. Before the birth, above around 70 subdivision is going to appear. Again here, we are going to divide some periods, some phase, the pseudogranular phase, that here you are going to find the terminal bronchiole. In the canalicular phase, you are going to find the respiratory bronchiole. In the circular, you are going to find here. In the circular, you are going to find some respiratory sac, but without maturing. And in alveolar phase, these alveoles are going to appear, and alveoles are going to get mature here during the childhood. This maturation of the alveole are going to be continued. Now it is possible you ask from yourself that the mature and immature alveole, what is the difference between these two? Look at this picture. In this picture, you are going to look at this alveolar duct. Alveolar duct here, at the first they are going to be covered by the cuboid epithelium. In the mesenchyme, around this alveole, the capillary are going to appear. These capillary at the first are far from this alveole. In the developing, during the 6 to 7 prenatal months that we call the circular phase, look at the capillary. Capillary are coming near the wall of this alveole. And what happened? The cuboid cells are going to get flat. They are going to change because the type 1 of epithelium, the nomocyte 1 or type 1 of the epithelium. The type 1 of the epithelium are going to appear here. With the developing, what happened? These capillary are going to protrude, they are going to protrude into this alveole. So here is going to form the air and blood bar. The air and blood bar. The capillary consists of one layer. The alveole consists of one thin layer. So the exchange of the gas is going to appear and happen very easily. In the newborn stage, this is a matched alveoli. So it is going to remember you the histological and function development of the human lung. In the fetal period, in the canalicular phase, in the fetal period, in the succular phase, it is better than this. And this period, that it is in newborn, you are going to find the mature alveoli. In this picture, you know that the mature alveoli are going to protrude the capillary inside of invaginate the capillary protrude the capillary inside of the alveolar exchange of the blood and the air is going to appear very easily. Do you have any question? Really?
Yes.
Okay, you explain this picture. You can read.
One can see
You can come here to the air.
I have a question. Is this information from which reference? Also, Drake's anatomy?
In this picture, I prepared for you from the line.
Not just this picture, but like all this entire presentation.
All
From-
the entire
from Langman.
No, they all of them belong to the Langman. Yes, don't worry. In your book, Langman is your reference.
Okay.
You can find all of this. Also, I uploaded this part in the Navi system with the voice.
Oh, okay.
Okay, don't worry.
So you recommend we study from this presentation
Yes,
of
this
Langman?
presentation in the Navi system with the voice help to you to know everything that are important for all of the exam. I'm going to explain for you the detail, some important articles, some important part of the respiratory development. Okay, explain.
Okay, from 16 to 26 weeks, canalicular phase, cuboidal cell lining the respiratory bronchi. Yes.
Okay, they are bronchiole and these are the cuboid folds. It is not mature. In developing, what happened after the 26th week means after 6 and 7 months. What happened in the developing of this bronchiole? What happened?
Very thin.
Yes,
Become very thin.
the canalicular changed to saccular. What happened in saccular? This cuboid cell changed very to the flat epithelium. They are going to become thinner. Here is thicker, here become thinner. This becoming thinner help to the capillary to be able to protrude inside of this alveoli. Okay? And we continue.
Newborn stage thin squamous epithelial cell type 1 alveolar epithelial cell and surrounding the capillaries.
When this cuboid cell become flat and thin, we call the epithelial and alveolar epithelial cell, or we can call type 1 or nomocyte type 1. So when the cuboid cell become flat and thin, the name change to what? Alveolar epithelial cell. Okay? They are going to make a bar between the epithelial and the alveolar. Epithelial belong to the capillary. And here you are going to find a bar. You are going to find a bar between the capillary and the thin layer, one layer of this epithelium. We call the alveolar epithelial cell, or we can call the type 1 or nomocyte 1. Okay? The name changed to type 1 or nomocyte type 1 cell.
Can we say it is the same mechanism? It's resembled to lacuna and the placenta in the beginning of formation of placenta. The same mechanism.
Yeah, all of them are going to happen accompanied to each other, associated to each other. Okay, all of them are going to happen. Now look at here. Inside the lumen here, at the first, in the fetal period, you have liquid. This liquid, before the birth, this liquid consists of a more amount of the chloride, a small amount of the protein, and the mucus. Mucus is going to prepare by the mucosal epithelium. So the gland of the mucosal prepare the mucus. The chloride is going to increase. The protein a little inside of the liquid, inside of the lumen of this part of the alveoli. But you should know, this liquid is going to absorb or resorb by the capillary of the blood and the lymphatic capillary. So lymphatic capillary cell and the blood capillary are going to resorb this extra fluid that is going to be appear inside of the alveoli before the birth. A small amount of this liquid remain in this lumen, and you know exactly after the labor, at the beginning of the birth, you are going to remove the extra fluid, yes, from the lumen of the respiratory system. The surgeon, the gynecologist, exactly after the labor, after the birth, is going to removing some extra fluid that is inside of the respiratory system. Explain this extra fluid. You should know, in the 6 months, something happened. The alveolar, in the 6 months, another alveolar cell are going to appear. We call the type 2 nomocyte. We call type 2 nomocyte. At the end of the year, 6 months, you are going to find another type of the cell that we call the nomocyte or type 2 epithelial alveolar cell. This type 2 epithelial and alveolar cell are going to be appear at the end of the 6 months. They are going to prepare for us, they are going to produce the surfactant. Have you ever heard the surfactant?
Yes.
This surfactant is important and it is useful. Without the surfactant, make problem for breathing. What is the function of surfactant? If you look at to the lumen of this alveole, this surfactant, this phospholipid is going to be found inside of this liquid. When the capillary, the blood capillary, the lymphatic capillary are going to resorb this fluid, this surfactant remain here. This surfactant is going to make a thin layer of the lipid in inner layer of the alveole. This surfactant is important for survival. This surfactant lowering the tension of the wall of the alveole. So lowering the tension of the alveoli. Without this surfactant, the alveoli are going to collapse atelectasis. But the surfactant inside of this fluid, after we removing this extra fluid, after removing and resolving this extra fluid by the blood capillary, by the lymphatic capillary, this lipid coat, this phospholipid coat is going to work such as a protective. It is protective. It is going to decrease, to lowering the tension of the wall of this alveoli and prevent the collapse, prevent the atelectasis. Do you get that? Surfactant is going to prepare by which time?
Type 2.
By 6 months.
6 months.
The end of the 6 months.
With which epithelial alveolar cell they are going
Type
to?
2.
Type 2.
Type 2. Okay, nomosis 2 or type 2. And this lipid, what is the function?
It's
Reduce
makes it
surface
easier.
tension.
It breaks the surface tension, makes it easier for the gas exchange between them.
Yes, but it is essential for us because when we absorb the fluid, this surfactant works such as a lipid coat lining the inner layer of the alveoli and prevent collapsing, prevent atelectasis. You should know, at the last 2 weeks before the labor, before the birth, at the last 2 weeks, the amount of the surfactant increase. The amount of the surfactant increase. This increasing of the surfactant is going to come inside of the amniotic fluid. This surfactant is coming at the last 2 weeks, coming inside of the amniotic fluid. It is going to stimulate, to activate the macrophage. This macrophage is going to pass through the chorion, enter to the uterus. Here, it is going to prepare a protein, an immunosystem protein that we call the interleukin. This immunosystem protein is going to increase the prostaglandin, and this prostaglandin is essential. This prostaglandin is going to begin to start the contraction of the uterus muscle. So the labor, the birth is a signal of the fetus. Do you get that? Means during the last 2 weeks, something happened. The increasing of the surfactant is coming into the amniotic acid, into the amniotic fluid. In the amniotic fluid, they are going to stimulate, to activate the macrophage. These macrophages are passing through the chorion, go inside of the chorion, and prepare the prostaglandin. The prostaglandin is going to begin to stop the contraction of the muscle in the uterus. Means we can see that the labor is a signal from the fetus. Now we can find so many abnormalities. I told you that the increasing of the retinoic acid is going to change something in foregut, and the respiratory diuretic fluid is going to appear. Now imagine in 2 locations you find the respiratory diuretic fluid. So you are going to have 2 lines in one side, okay? It is possible you have ectopic lung flow. So many effects, so many congenital problems, it is possible to appear. This diagram is going to remember you the signal of the birth, signal of the labor that is coming from the fetus. It is going to remember you that what happened, that this amniotic fluid is going, the surfactant is coming here, They are going to stimulate the macrophage. This macrophage passing through the chorion, and they are going to contract the muscle of the uterus. Breathing movement, what do you think? It is going to happen to appear in the fetal period before the birth or after the birth?
After.
No. The movement, the breathing movement is going to start to begin before the birth. Okay? This breathing movement is essential for developing of the lung. It is essential for developing of the lung, for developing of the cartilage, muscle. But you should know that at the birth, when the respiration begins, most of the lung fluid is going to resolve. What do you think? Which structure are going to resolve?
Capillaries?
The capillary of the blood and the capillary of the lymphatic system. And what happened to the rest of the fluid inside of the alveoli? What happened? Who is responsible to remove?
Alveolar sac.
Yes.
Reabsorption.
After the birth, I told you, the surgeon, the doctor is going to remove the extra, a small amount remain, the extra small amount from the respiratory tree. And what is the function of the surfactant?
It doesn't do any function before birth.
Yes, but after the
It
birth,
prevents
when the fluid resolve, this phospholipid surfactant remain in inner layer of the alveoli, and it is going to lower and to decrease the tension of the alveoli, and it is going to prevent the collapse or atelectasis of the alveoli. Okay? So something that I explained for you today about the embryology, it is important. It is possible in your book you find a little more, but something that I explained for you in the class is enough for this semester. Okay? If you want to increase your knowledge, you can read carefully all of the detail in your book. No, okay? Now, what's the time?
11:50.
11:50.